I'm Harriette Van Spall, cardiologist from Canada, and I'm so delighted to have Julie De Backer, who is a cardiologist and geneticist from Ghent Hospital, who was the task force chairperson for the ESC Guidelines for the Management of Cardiovascular Disease in Pregnancy, and she is here to give us her tips for managing patients who are pregnant with cardiovascular disease. Welcome, Julie.
Well, thank you very much for inviting me. It's a pleasure to be here, Harriette, and look forward to this talk.
I am so happy that you presented these guidelines. Pregnancy can be complicated by cardiovascular-related morbidity and mortality. And I wonder, before we start talking about the guideline update, if you would give us a very brief overview of the top cardiovascular risks and underlying conditions that pregnant women with heart disease face.
Mm-hmm. Yeah, well, thank you for the question. Indeed, pregnancy and cardiovascular heart disease, because we have modified the title coming from the previous version, which was in 2018, and which said Management of Cardiovascular Disease during pregnancy. We changed that to Management of Cardiovascular Disease and Pregnancy. And with that change, we want to emphasize that pregnancy encompasses a much longer period than the nine months of gestation. So the management should start well ahead of pregnancy in those women who, of course, are known with cardiovascular disease, and should extend until late in life, as we all know by now. Cardiovascular disease complicates about 4% of all pregnancies, as has been shown in American data mainly, which is not a low number. And if we also include hypertension into those numbers, then we come up to 10%. So hypertension for sure is the most common cardiovascular complication in pregnancy. So that's one thing. The numbers of pregnancies complicated by cardiovascular disease are also rising. So, and there's several explanations for this trend. There's more women with congenital heart disease who reach reproductive age and who will engage in pregnancy. There's women who have had treatment for severe diseases, and talking about cancer treatment. There's also a number of women who have had a heart transplant, and young women who want to have children. So that's a very small minority, but still it's a complex group. And then of course there's this bulk of women who postpone their first pregnancy until later in life, and then it's no surprise that in this group we will see more common cardiovascular risk factors, hypertension being just one of them. But it's an increasing group of women that we have to deal with, and well, I think this is one of the main reasons why, as you say, why we need these guidelines.
Sure. So there's cardiovascular disease, and then there are cardiometabolic risk factors that increase the risk of complications in the peripartum phase. I wonder if we could focus on the new recommendations for managing cardiovascular risk in the peripartum period. How about starting with cardiomyopathies that could be high risk and put women at an increased risk of death? What are some of the class 1 recommendations around managing these patients in our new guidelines?
Yeah, so cardiomyopathies, we have actually two separate chapters on cardiomyopathies in the document. So there's one chapter on the inherited cardiomyopathies, and then there's a specific dedicated chapter which is needed in a document on pregnancy on peripartum cardiomyopathy. So it's you can find the information in there. An important change, and this does not only apply to the cardiomyopathies, but an important, critical change actually that we made in this document is that we have in the previous guidelines, we had a class 3 recommendation. So pregnancy is not recommended in women with very high risk. And talking about cardiomyopathies, we are, for example, talking about women with decreased left ventricular function or severely decreased function or a severely increased gradient, as we sometimes encounter in women with hypertrophic cardiomyopathy. And there we now have a class 1 recommendation saying that these women need expert counseling well ahead of pregnancy, of course, to discuss the very high risk of pregnancy, and so that they are aware of this, and that they are also offered possibilities for termination of pregnancy in the case that they are already pregnant, and that they should get proper psychological support to make their decisions. So it's, to me, that's one of the critical changes in our document. So removing the class 3 and changing that to a class 1, because we really want to respect the autonomy of these women in their decisions, and we want to engage in a shared decision model process when it comes to these changes. So that's a class 1 recommendation. Women with decreased function and with severe gradients should have expert counseling about their risk. So another clear-cut recommendation is that these women in higher risk groups need to have their follow-up in the pregnancy, in the setting of a pregnancy heart team. So we have dedicated a full chapter on the pregnancy heart team in our guideline document, explaining what this should look like and who should be in, which experts should be in, but also which women should be included in the pregnancy heart team and which women should not. So that's an important change that we have made as well. And then we have some recommendations about the need for heart failure treatment in these women, which of course, now with the new, they're not that new anymore, but still the newer drugs for heart failure, many of them need to be avoided in pregnancy. So again, I want to emphasize that it's really critical that women known with a cardiomyopathy should be seen pre-conception and should be counseled pre-conception, evaluated pre-conception. Drugs might be changed or stopped, or the treatment should be adjusted, and then they should have their re-evaluation. And in some cases, you may start treatment if you see that the heart function is going down. So I mean that's the basic and the main recommendations that we have wanted to make.
So you talk about hypertrophic cardiomyopathy with severe obstruction, and you talk about severe LV dysfunction as being high-risk conditions around which women should receive counseling pre-pregnancy. Can you name some of the other conditions that were deemed high risk, necessitating informed decision-making? Pulmonary arterial hypertension, congenital disease comes to mind with Fontan circulation, but can you give us a list of top conditions that you would be concerned about?
Yeah, so you mentioned two important entities already. So indeed, pulmonary arterial hypertension. These women are at very high risk, and even there's now some data coming out that maybe the ones with milder forms of pulmonary arterial hypertension might be at a lower risk, but still we know that this disease can evolve in a bad way during pregnancy, and it's very difficult to predict. So that's definitely a group of women that need this expert counseling, especially when they are taking these PAH drugs, most of which are contraindicated in pregnancy. So that's definitely a class 4 or a class where we need this shared decision and expert counseling. Another group, indeed, the Fontans you mentioned. So women with a Fontan circulation and with any complication are definitely also in this high group. And in this particular group, it's It's actually it's more the fetal risk that appears to be very high in this entity. The risk for maternal complications, well, it's definitely increased, but it's less severe than the fetal complications that may occur. So preterm delivery and preterm rupture of membranes and all kinds of complications that you do not want. And then two other important entities that fall under that category are women with vascular Ehlers-Danlos syndrome. So this was also a group that was considered or had a class 3 recommendation. So pregnancy is not recommended. This is also, we have also changed that in this setting, and a little bit related to this is women with a previous aortic dissection, where we have also removed the class 3 recommendation and changed that to a class 1 for counseling. And I think for these women, it's an important message. We all know that something we want to all avoid is that women are told you should not become pregnant, that they get frightened, and that they get lost to follow up. And that's even a higher risk. We thought that if we tell them that they have a very high risk, but if they really want to engage in a pregnancy, we will continue their follow-up, we will continue their management, and they should not run away from the care. So we hope that with this change we have made this
so
more
we
clear.
discussed high risk conditions that require thoughtful deliberation prior to conception and the decision to become pregnant. How could patients who want to proceed with pregnancy be managed? You mentioned the heart team. Are there any biomarkers or clinical indicators that received recommendations from these guidelines?
Yeah, that's a very important question as well. So again, pre-pregnancy counseling and pre-pregnancy evaluation is critical in this setting. And all women with, we have modified the MWHO risk classification table. We have now extended this. We have added more diseases. So we hope that this will also be helpful for caregivers. So please have a look at this table first and advise your patient and tell them in what group they are. The class 2 and 3 and above need a pregnancy heart team, and class 1 and 2 can be managed by regular care. It's also important for everyone to not overuse the system. But with regards to pre-pregnancy evaluation, we have had long discussions about the use of biomarkers. So we know that, for example, the NT-proBNP values, they're kind of pregnancy specific. There's changes that occur during pregnancy, but we have recommended that these biomarkers can be used in a serial way. So you should have a baseline value, early on in pregnancy, and then if symptoms get worse, or if these women have an adverse course during their pregnancy, you might have some use in the evolution of these biomarkers. So definitely, that's one of the biomarkers that we recommend. We have also discussed the use of troponins, but yeah, there was no consensus there, and I think the data are a little less strong. So BNPs can be used, and then obviously evaluation with exercise testing prior to becoming pregnant might be very valuable, especially in those cases with, for example, with heart failure, where you need to adjust treatment because they're on drugs that you cannot continue during pregnancy. It's really important and necessary that you take these evaluations ahead of conception.
So I'm going to go through a list of conditions and ask you for your top 1 or 2 takeaways for each. Safe drugs during pregnancy and lactation for peripartum cardiomyopathy. Can you summarize those for us?
Yeah, of course. So peripartum cardiomyopathy is an entity that occurs mostly at the end of pregnancy, and importantly can also occur after delivery. So it's important to acknowledge this, and it's easier in women who have delivered, because then you're free to use conventional heart failure strategies and heart failure treatments. During pregnancy, you cannot use the Entrestos, also the ARNIs, the SGLT2 inhibitors. They are not, well, there's not enough safety data on those drugs, so you cannot use those. There's an ongoing discussion about the usefulness of bromocriptine. There's a big trial going on in the States, and I think we're all looking forward to those results, which we do not have yet. It's a prospective trial. For now, we have that as a class 2B indication to use bromocriptine in the setting of peripartum cardiomyopathy. And if you do, make sure that you also give these women anticoagulants or molecular weight heparins to prevent thrombosis. So that's in a nutshell peripartum. And don't forget genetics. Just want to make sure that
and beta blockers.
And beta blockers, of course. I mean, beta blockers, yeah, and diuretics. Well, not all diuretics, but some diuretics can be used for symptom relief in these women. Yeah.
And what digoxin?
Well, the digoxin is not a contraindicated drug in pregnancy. It may be considered. It's not considered as a first line, but in some indications, especially when arrhythmias come into play, then this might be a useful option.
Mm-hmm. How about long QT syndrome and other high-risk primary arrhythmias? What are your top recommendations for those?
Yeah, so again, these women who are known with these diseases should be seen ahead of pregnancy, because also especially in this setting, genetics play a role. So these women should be counseled about the inheritance risk as well. So most of these inherited arrhythmias are inherited in an autosomal dominant way, which means that the child has a 50% chance of inheriting the disease. The women should be counseled about reproductive options, and this should be discussed definitely. Regarding drugs, so nadolol is one of the preferred drugs in many of these diseases, including long QT and CPVT. And women who are already on these drugs should continue them during pregnancy. All women with beta blockers, whatever the indication, should have monitoring of fetal growth, because we know that these may inhibit fetal growth, so they should be carefully monitored. The only beta blocker that should not be used is atenolol, so we have put that also in our recommendations, that atenolol is a contraindicated drug. A specific situation maybe also is long QT syndrome type 2, which poses an important risk in the postpartum period. So make sure to continue an appropriate dose of beta blockers in this setting, because these women are at increased risk for severe arrhythmias once they have delivered.
Sure. How about venous thromboembolism? What are the new recommendations for that condition?
Yeah, so we have provided recommendations for prophylaxis of venous thromboembolism, taking into account the various risk factors for thromboembolism, the thrombophilia factors that come into play there. And then in the setting of a venous thromboembolism occurring during or after pregnancy, and again, VTE is something that has a higher prevalence towards the end and shortly after delivery. So think of not only of deep venous thrombosis, but also of pulmonary embolism in women who have delivered recently. An important message we wanted to bring is that these women should have proper evaluations for DVT or for pulmonary embolism, and there should be a very low threshold to start these evaluations in these women. So do not hesitate, even in the setting of a pulmonary embolism, to go for a CT scan if it's needed. If you really need it for your diagnosis, then you should not withhold these women of proper scanning, even during pregnancy. And if diagnostic delay is anticipated, it's wise to already start treatment with low molecular weight heparins and not wait for the final results in the setting of an anticipated delay in diagnosis, of course.
How about your top recommendation for 2 more conditions? Hypertensive disorders of pregnancy, common condition with potentially high-risk sequelae for both the mother and child. Can you give us the target blood pressure and the top therapeutic approaches to maintain blood pressure under that range?
Yes. So we have provided a uniform threshold to aim for when it comes to hypertension. So we recommend that all pregnant women should have a blood pressure below 140/90. So that's irrespective of if they had previous hypertension or not, or if the high blood pressure developed during pregnancy. So that's one recommendation that we have made clear. All women who have a blood pressure above 160/110 should be admitted to the hospital. That's an emergency situation, and these should not be sent home. They should be hospitalized for further evaluations. And in all cases of developing hypertension during pregnancy, you should also always be wary about preeclampsia and perform the necessary tests to exclude preeclampsia, because this requires a strict treatment and follow-up. And depending on the height of the blood pressure, you will go for oral treatment. Again, methyl dopa is still one of the preferred drugs during pregnancy, not after delivery, because there's an increased risk of postpartum depression with that drug. But again, beta blockers may be helpful, and then nifedipine is still a very valid drug that you can also give. And in the setting of severely elevated blood pressure, you will for sure go for IV administration of these drugs. You can also use nitrates, for example, in this setting. So it's similar than. To a certain extent, it's similar from treatment outside pregnancy, except that you cannot use ACE inhibitors or ARBs. Of course, that's not recommended in pregnancy.
Sure. And how about the person who is pregnant and presenting with chest pain and suspected coronary artery disease? What are some of the top takeaways around that presentation?
Yeah, so one important message that we have also wanted to bring in our guidelines is that, and this is especially useful, I think, or we hope, in the emergency setting. Do not treat a pregnant woman with chest pain or with any emergency different from a non-pregnant woman. People should not be afraid, or these women should not be withheld diagnostics or treatments when they encounter an acute situation. So a woman with a cardiac arrest should be resuscitated according to the common recommendations. There's a few very specific points of attention that you have to consider. It's important to shift the uterus to the left, so to decrease the pressure and to guarantee that the venous return is okay, so that the pregnant uterus does not compress the preload or to the heart. And it's also wise if you need the insertion of IV lines, to do that above the level of the diaphragm. So no IV lines in the femoral vessels. That's not a good idea. Amiodarone during pregnancy is a contraindicated drug, but again, in an emergency setting, this drug should be given. You should aim for survival of the woman in this setting, and in the case of acute coronary syndromes, again, one important and pregnancy-specific entity, of course, as we all know, is SCAD, so spontaneous coronary artery dissection in this setting. And to diagnose this, you need a coronary angiography. So again, women with a high suspicion of an acute coronary syndrome should have a coronary angiography for the diagnosis. And if they need a PCI, they need to get a PCI in the setting of an obstructed coronary artery. So you can use aspirin after stent implantation. If needed, you can add clopidogrel if you need dual antiplatelets. Well, there's some drugs like ticagrelor is not recommended during pregnancy. So we have provided a list. We hope this will be a helpful list of drugs that are safe, drugs that should be avoided, and drugs where you should use some caution in our document. And yeah, please consult this. We hope this is a useful list.
Sure, remarkable guidelines, a huge set of recommendations, and perhaps striking to researchers is how few the class 1A recommendations are because of the lack of evidence and clinical trials in pregnant and peripartum women, and how many historic medical therapies we continue to use in pregnancy because of the lack of data. Thank you so much, Professor De Backer, for sharing your expertise with us and for spending time reviewing some of the highlights of these ESC guidelines to manage peripartum women with cardiovascular disease. Thank you so much.
It's been a pleasure. Thank you for inviting me.